Good morning, colleagues. I am Dr. Shanti Singh Anthony. Welcome to today's webinar on COVID-19 vaccines and people living with HIV. Welcome on behalf of my director, Dr. Rosman Adams. We're pleased that you're here with us this morning. As you know, we're almost 2 years in the COVID-19 pandemic, and at the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, we continue to respond to the knowledge needs of our stakeholders. People living with HIV in the region have had many questions about COVID-19 in general, and more recently in relation to the vaccines and the booster. There are questions, for example, on how COVID-19 vaccines affect their HIV treatment. How does COVID-19 vaccines impact on someone living with HIV who also has comorbidities such as diabetes, hypertension, asthma, and other illnesses? Today's webinar really will focus on addressing some of those questions and key issues and concerns of the community. At this point, let me remind our attendees and participants of a few housekeeping points. This webinar is being recorded. The recording will be shared on PANCAP's website and social media platforms for the benefit of those persons who could not have been with us at this live session. Your mics are muted. If you have any questions, please type these, submit these in the chat bar of your webinar panel. We'll address the questions at the end of the presentation during a question and answer segment. At this point, I'm going to go ahead and launch a poll. Let me see. Yes, so there's a poll up on your screen. The poll is anonymous. Please go ahead and participate. At the end of the session, you will receive a certificate of participation. This will be sent to you via email. You will also receive a post-webinar evaluation. I ask that you please complete the survey that's being sent out. Your feedback is really important to us as we continually strive to improve your webinar experience. Like I said, please participate in the poll. Good, perfect. So I'll go ahead at this point and introduce our first speaker. Dr. Moti Ramgopal is an infectious disease specialist. He graduated with his medical degree from the University of the West Indies in 1989 and completed his fellowship in infectious diseases from the University of Miami in 1997. He is the medical director of Midway Care Specialty Center Incorporated for Florida, Guyana, and Trinidad and Tobago. Dr. Ramgopal has been integrally involved in HIV treatment and research from the inception of the HIV epidemic. He's been involved in numerous clinical studies and trials for almost every HIV medicine that we're using. Currently, he is also involved in some of the cure studies that we're to hear about in the future and in clinical trials with long-acting injectables. In relation to HIV further, Dr. Ramgopal served as the PEPFAR Country Medical Director for Guyana from 2008 to 2011. With the HIV COVID-19 pandemic, Dr. Ramgopal has managed many COVID patients, both at an outpatient level and in the hospital. He has been involved in most of the clinical research around COVID-19 treatment, including for remdesivir, Regeneron, and most recently for molnupiravir. I now invite Dr. Ramgopal to make his presentation on COVID-19 vaccines and people living with HIV. Over to you, Dr. Ramgopal. Let me close the poll.
Thank you. Thank you, Dr. Singh, and thank you, everyone. Thank you, PANCAP, for inviting me to do this presentation. It's indeed a privilege and a pleasure to do this today. I know we're in the midst of very difficult times, and thank you for the kind words of that introduction. So let's jump into the first slide I have is to just refresh your memory what that pandemic that we were so worried about before COVID came along, called HIV. And the point I want to look at this global map is that here we are, almost 35 years plus with the HIV pandemic. We've had over 36 million deaths, and we have actively about 35 million infections currently around the world. You look at the United States, you look at Brazil, you look at China, India, you look at East Africa, South Africa. Look at these hot areas on the map and the endemic areas. And these are the high population density for HIV around the world. And then we jump into the COVID story. And here's, even though this map was taken over a year ago, and this was only when there were 3 million cases around the world and 256,000 deaths. We're now at over 250 million cases and over 6 million deaths, 5 million deaths. So when we look at the hot zones again, the heat map, you see United States, you see Brazil, you see there in Wuhan, China, where it started, and then out throughout Eastern Europe, and then here's South Africa. So these two maps quite mimics each other, kind of like an overlay of each other. So pandemics, as we can clearly see, follows each other over time. And I was kind of puzzled when I didn't even recognize this until I was doing these slides. I said, wow, this is quite similar. Looking at these maps, looking at the countries affected, looking at the geographical distribution of these two viruses. And then we ask ourselves the question. I remember a year and a half ago when the COVID just hit the United States, I made some calls just even before it hit, about a month before. I made some calls to some friends of mine who are ER physicians, and I said, this is going to be the worst thing we're going to see in our lifetime. And this COVID is not going to go away for quite a while. We need to be prepared for this, and you need to be careful and be cautious what's going to happen. But little did I expect a lot of things to evolve. One, I didn't expect that I'm going to see the comorbidities that we saw. Sure, we always say, well, if a virus of a respiratory origin invade our system, people with underlying diseases will be terribly affected. Elderly people, for example. I remember sitting in front of my emergency room one day, and there were like 12 EMT vehicles parked in front of that emergency room, just pulling in bodies and bodies of elderly people from the nursing homes. And that was the first wave we saw. And then they had underlying diseases, cancer, cardiac disease, cardiomyopathy, and the chronic kidney disease, the dialysis patient, the renal transplant patients. These were the ones that were very early in the story. But the one that really puzzled me tremendously and puzzled everyone was diabetes story. Everyone would come in with high blood sugars, diabetes out of control, and our treatment strategies had to be more, here's a viral infection, what can we do? What can we treat it with? What are the options on the shelves? We were trying to throw everything at patients at one time, using drugs that we don't use anymore. And then we had a study out of the UK saying, well, there's a role of steroids. Prior to this, we were saying, don't use steroids, don't use this. So there's a lot of severe, significant confusion in the first 6 months. Thankfully, we were able to iron out these confusions. We looked at the data, we looked at the studies, we looked at the comorbidities. The comorbidity that jumped out at us more and more was obesity. I looked at patients in the hospital, 300 pounds, 400 pounds, 500 pounds. And more so, as the moment they came in with obesity, I would kind of have a casual predictive formula whereby obesity plus high blood sugars and plus asthma or COPD, ultimately these patients required high oxygen concentrations very quickly. They required proning, they required ventilation, and the mortality in that group was quite significant. And it was kind of after a time, it became very depressing when you see an obese person presenting with COVID, to respect that this disease doesn't spare those patients. Pregnancy was a huge issue with us. We saw a fair amount of young in the 20s and 30s pregnant women who are now presenting with shortness of breath, presenting with comorbidities, and presenting now with COVID symptoms requiring oxygenation. And several of our patients died who just after delivering babies, a week or two, they remained on the ventilator. And their progression was quite rapid, it was quite abrupt. And some of these patients died of pulmonary embolism and complication of COVID. And of course, smoking. And then we started asking ourselves questions, what about potential risk factors? Who are these patients? And as the first wave, the first variants came up, first the original COVID-19 virus recircled the globe, and then we went into the mutations of the Delta and the and the different mutations. And when we saw these new mutations, what we did see is that here's younger people now getting infected. Here, younger people with asthma, moderate to severe asthma, progressing quite quickly to shortness of breath, requiring oxygen and intubation. People with hypertension, liver disease, neurologic conditions, dementia was the older population. But then we see a lot of depression now. And I think depression is now added as one of the known risk factors in COVID-19. Then we questioned our HIV patients. My clinic is on the east coast of Florida. I have about, I'm just north of West Palm Beach. I have over close to 1,500 patients that I've been following for the last 10 to 15 years. And then my question to my patients were, to my nurse practitioners and physicians were, are we going to see our HIV patients being infected? Are we going to see a lot of challenges with HIV patients? Because because HIV, as we know, has a disruption of our immune system. It's low CD4 count, CD8 goes up, and then when there's recalibration with treatment, your CD4 goes up. And then what about HIV patients with comorbidities? I recall one of my patients who was a survivor of 9/11. She was an EMT worker in 9/11. I first saw her about 12 years ago, and at the time when I saw her, her CD4 count was less than 20. Over this long period of time of treating her, she's now moving into her mid-40s, and she developed diabetes and other complications. And she's one of the first patients in my practice to get COVID and to die from COVID. And she had underlying lung disease from the 9/11, as a rescue worker exposed to air, contaminated air in New York at the time. And this is what happened. So this is one of the sad cases. I remember seeing her on the ventilator, calling the family. And this is very, very early in the COVID story. So I said, wow, am I going to see more of my HIV patients being infected with COVID? And what's that going to look like? So then I also recall that, well, here she was. She had a lot of underlying disease. She had COPD. She was diabetic, and these also contributed to her COVID story. So then when we look now around, early last year, we looked out to the UK. Well, we look at patients. What is our aging population of HIV looks like? Over 50 years now, over 50% of our patients are over 50 years. 97% on ART in the UK data. In my clinic, it probably looks exactly the same. And viral load measured, constantly we check these numbers. And then we look at the comorbidities of our patients in our practice today who are over 50. What does it look like? Hypertension, dyslipidemia, depression, renal impairment. Obesity in the UK population was only 11%. In my clinic in Florida is about 30% of BMI greater than 30, and that's quite a large number. And diabetes is an increase in my population, as well as osteoporosis. So multiple comorbidities with HIV is truly pushes really tells us another story here. So not just about the immune dysfunction that we have related to HIV now, it's a question of comorbidities. But is this real, or is this just we're just postulating this? So we looked at the early data. Small study came out of New York, the 36 people with HIV confirmed very early with COVID-19, and they looked at the total numbers. The age group is in the 50s. Hospitalized, average age was 55, and not hospitalized was 50. We look at comorbidities with high-risk comorbidities. 85% of them had comorbidities with a high risk, and hospitalized and not hospitalized was just a smaller number, was 80%. Male was 61% and 53% in the non-hospitalized. But what we looked at also was African American, Hispanic, Latinx, and about 80%, even though again it was a small study of 36 patients, it was a signal. It was a signal to say, well, African American people, individuals with HIV, Hispanic, Latinx with HIV, these are patients we need to start asking the questions, what's that going to look like? And also more than 50% had exposure to congregate settings or groups of people. So the question we'd ask ourselves is that, one, why HIV may worsen outcomes, and what does that look like? And I think when you look back at this, I thought that, okay, well, here's immune deficiency dysregulation, and now comorbidities added to the story, as well as social determinants of disease. And then the question is why people with HIV may not worsen outcomes, because we always say, well, these patients now recognize that here's another virus, let's stay home, let's wear a mask, let's keep away. A lot of my patients very early didn't refuse to come to the office. A lot of them said, I'm going to do televisits. A lot of patients were very, they've been exposed to a virus for 20 years, 15 years, 10 years. So they were much more prepared, in my estimation, than a lot of other people who have not been exposed to a chronic virus. So they kept their distance, they were prepared, they kept away from people. And so the question also was that they were on art. We said, well, would tenofovir have a protective influence? Would the protease inhibitors have a protective influence? And that question is still unanswered. I still see abstracts postulating that there may be some benefits of antiretrovirals, but we're not very clear yet. We can't make a statement loudly that say, yes, patients with HIV have been protected from COVID because they're antiretroviral, but it's still a question that needs to be answered at some time. And then this slide just looks at what the complex immune response to SARS look like. We hear a lot of stories about, but it's a very complicated virus. It's not as easy as just a rhinovirus, as a simple adenovirus. It's a much more complex interaction of our immune system. And we saw that very early. Here's a virus attacking our lungs. Okay, the virus probably goes away after 5 to 7 days. But then we saw people progressing by day 10 to respiratory problems, increasing difficulty breathing, interstitial. You look at your chest x-rays, interstitial infiltrates, ARDS within a matter of a few more days, being on the ventilator. So we started thinking, well, if you have a low viral titer versus high virus titer, as we've seen in most viral infections, if you have a low viral exposure with a mask on, or a low viral exposure with someone on the end stage of their viral illness, it may be a mild result, mild normal immune response, recovery. And we saw that probably in about 80 to 80% of people out in the world, that, okay, you have a mild viral infection. But then if you have a higher viral titer and you have you have comorbidities and other reactions, you can have a really severe, inflammatory process. And then we recognize that this whole process of cytokine storm, what does that look like? It's a macrophage function. It's a lot of inflammation in lungs, even microthrombosis at the pulmonary level, at the capillary level. And then what does this cytokine storm look like? It's the interaction between CD4, CD8 T cells, neutrophils, releasing IL-4, IL-6, IL-10, and tumor necrosis factor. And this complex interaction makes us wonder, okay, CD4, CD8, we're familiar with those names. We've seen that with HIV for quite a little while. How is that going to affect our HIV patients? And then with the severe patients, they develop this antiviral and this viral, post-viral cytokine storm. And what treatment did we have? Steroids, remdesivir. We tried a lot of different adjunctive treatment, oxygen, a lot of different strategies we implemented over time. Blood thinners, oral blood thinners, intravenous blood thinners, a lot of these just to delay or slow down this cytokine storm process. But there is lung injury, sepsis, and death for a small percent of patients, but it was quite significant. Our ICU beds immediately went from 1 to 15 to 20 to 25. We had to get more ventilators, more beds for patients as the numbers increased throughout the hospital. We have been through 3 horrific phases of this. We have three massive numbers where our hospitals were inundated. The healthcare workers were challenged at different levels. And then we always ask the questions, what does an adequate immune response look like? What is an inadequate immune response? As you can see listed here is a complex mechanism. It's not just diabetes, it's not just obesity, it's not just a virus. It's about your interferon response. It's about the activation in your body of this appropriate antiviral response, your interferon release, activation of Th1 cells and B cells to develop neutralizing antibodies. And if these are done very quickly, you can probably slow the virus down. But then again, if they're done in a rapid phase, it can lead to that cytokine storm we talked about. That leads to endothelial cell death, that it leads to leakage, that leads to ARDS, that leads to overexhaustion of the immune system. And patients after 2 to 3 weeks finally succumb because the nutrition becomes an issue, muscle weakness becomes an issue over time. So the whole SARS-CoV story is really is a whole complex mechanism that is evolved, and the more we understand it, the more we recognize the challenges we face it. I dealt, as an infectious disease physician for the last 30 years, pretty much in my mind, and I finished in 1997. But when you look back at HIV and what it did to understanding virology, I keep telling a lot of my pulmonary friends, what we're learning from SARS-CoV-2 is now preparing us for the next probably deadly infection. HIV prepared us to some extent to understanding SARS, and now we're going to be prepared now for the next project, which may be 10 years, 20 years, 30 years from now, we don't know. As we keep hearing more about the variants, we keep wondering about that story. But the question early on was that was there evidence of association between HIV and worse COVID outcomes? And what evidence was there? Was there good evidence or bad evidence? So very early, there's mixed messages coming out. In New York City, we had 21 patients with COVID-19 and HIV. They were uninfected 42. When you compare those, there were no increase in ICU admission. So then there was a multi-center study, 404 with HIV and COVID, uninfected with COVID was 49,000. And when we do look at those numbers, we see that there was no increase in mortality. When you look at the outcome in these 5 studies, there's no outcome. So we said, well, there's not really a signal here. The HIV patients doing well. But then that, I don't think that answered the question, because there's a lot of, as I mentioned, one of my first patients, in the early epidemic, I saw one of my patients die, and I saw a few others over time. So there must be a signal there somewhere. And then the next question was, if there's a signal, what does those patients look like? And this is out of some of the New York State Health Department cases, and they found a signal. They saw that if you have HIV positive and you have COVID, your mortality increased 1.6 to 2.3 in the UK data, to 1.47 in the UK, to 2.1 in South Africa. So some of these were adjusted studies, some of these were matched studies to the similar arm, but these were still some of these were observational data. So it's interesting to see now, can we now correlate this observational match data to what we're actually seeing more and more in clinical practice? And this is what we see also. This was a very interesting study of 100, this is a WHO global platform study of 168,000 patients from 24 countries. And I think what their findings was somewhat what was not quite surprising. Age more than 65, male, diabetes and hypertension increase the risk across the board of mortality from COVID. So this, if you have HIV, now you have COVID, you're over 65, you're male, you're diabetic, hypertension, the risk increases. And of course, you can add Latinx, you can add African American. These are all increased risk factors, as well as obesity and these other factors. The question to me was about the CD4 count. Would the CD4 count be impactful? Was that number, is it 200? Is that good enough? Is it 300, 500? Where are we going to see a flag? So they looked at 286 people with HIV and COVID-19 from 36 institutions, mostly from the US. 94% of those were pretty much on ART, so 88% were suppressed. And then the primary outcome looking at this data was ICU admission, mechanical ventilation, or death. Older age, so what they found, again, older age, chronic lung disease, hypertension, and lower CD4 cell counts were associated with decreased survival. I think adding the lower CD4 cell count now makes a louder statement that here's HIV patient with lower CD4 cell counts, you have a decreased survival. I think that looking at this data added that layer of now question. Now CD4 cell count becomes a marker now in the COVID HIV story. And then there was a separate analysis of the European cohorts that looked at CD4 cells, and they're saying less than 350 was associated with increased risk for COVID-19. And you can see this over time, day 10, day 15, by day 30, you see these decrease of survival over time with less than 200, between 200 and 500 and less than 200. So now we begin to recognize, we start looking at our patients who have less than 200 T cells as now a high risk category with COVID. So these are the patients now we need to start saying, we need to vaccinate them. We need to get more involved, because in our treatment strategy, our first treatment strategy was vaccination. And so of course there'll be questions, oh, well, is it going to be safe? Their CD4 count are low. Are they going to develop immunogenicity? Are they going to mount their immune response? What's that going to look like? At the present time, there's no data to suggest that vaccines are not safe for people with HIV. Of my 1,200 to 1,500 patients in my practice, over 90% of them are vaccinated right now. What I found interesting in society was that here I am having these patients with HIV, and here I am with patients with non-HIV, elderly population who refusing vaccine, and these patients with HIV were so accepting of HIV vaccine from very early. They were like, when am I going to get my vaccine? I'm now hearing a clamor, when am I going to get my booster? And I think that is a very eye-opening story, recognizing the fact that patients with HIV are so much more in control, knowledgeable about viruses and disease states than a lot of my educated neighbors who are attorneys or even physicians out there who are using ivermectin and things like that. we have a very knowledgeable population, and it's very good that now we can tap into that population and advocate vaccines in that population. So the clinical trials at the beginning included participants with HIV, but there were very small numbers in those initially. But however, we can clearly state that there have been no links between HIV vaccination and any serious side effects that we have seen. The exclusion to a vaccine will include a known severe allergic reaction to a component of the vaccine. As I've mentioned, I've given over 1,200 vaccines in my practice with boosters now, and I have not seen any severe allergic reaction to any of these components. So what does the vaccine development look like? The vaccine development, it was amazing how quickly we ramped up our vaccine story. I mean, a lot of skepticism about this, but it was clear that this process was in the works for many, many years. So when normally it would take 10 to 15 years to develop a vaccine, we compressed this to 1 to 2 years because a lot of these platforms are already being available. They're already being worked on. There are already previous studies with Ebola, previous study with HIV vaccine backbone, so mRNA vaccines with early SARS. So these are already there, and they were just in the backbone and waiting for an opportunity like this to ramp them up. So a high level process occurred. Right now, when we look across the slide, I say, wow, there's a lot of vaccines available. I mean, phase 1, 28 vaccines are in testing, phase 1 to 2, 23 combined trials, 15 vaccines in expanded safety trials, 9 combined vaccines, 32 vaccines in phase 3, 15 authorized in early or limited use, 8 approved. And of course, you look at that 10 abandoned. And it's important to recognize that 10 abandoned because the pharma companies lost a lot of money. Again, they were abandoned because of risk profiles, of many of efficacy profiles. So when we look at this slide, we realize there's a significant amount of safety, there's a significant amount of oversight that goes on into these studies, and it's the details and the strength of these studies is what evolves over time. And on a personal note, when the vaccines came out, I got my family vaccinated very early. And of course, I was saying, what are these mRNA vaccines? What can it look like? But getting vaccinated early is very important. And then recognizing that in the last wave in July, August, and September, what I saw in the hospital was like 99% of the people in the hospital were unvaccinated, and less than 1% or 2% of my patients in the hospital were vaccinated who were admitted. And then we asked the question, what do these vaccine candidates look like? There are multiple strategies, from DNA to RNA to live attenuated virus to inactivated virus to protein-based virus to non-replicating vectors. So there's an incredible amount of research that's going on around the world, an incredible amount of energy goes into this process to get to the next phase of developing better vaccines, or even the vaccines today are, because how can you beat 90% efficacy? It's very challenging to see that. I was in disbelief when I thought that this is not going to happen, then you're seeing that in the real world. So what happens after one dose of a COVID-19 vaccine? So what happens? So the mRNA vaccines need to be injected into the muscle tissue because they have a nanoparticle or envelope which need to be absorbed. And then the vaccine contents enter our cells at the injection site with the genetic material for the spike protein. So what they've done, they've mimicked the spike protein, and that's what the body works against now. The spike protein is now produced by our cells and presented on their surfaces. This goes to lymph nodes and the train our response. That's why some people have lymph node swelling, painful lymph nodes, because this is the immune system revving up right now. It's revving up to a new virus. It's a novel virus. It's never been exposed to this virus, so that you have this higher level of production of antibodies. The T cells are activated now. So which T cells? The helper T cells. Those same helper T cells that decline over time with our HIV patients, these are the ones that are ramping up now. They detect the spike protein and alert our other immune cells. They take the message. The killer T cells now are ramped up. They seek out the spike proteins, and now we develop antibodies by the B cells that create and to recognize these spike protein. So again, it's a complex mechanism. It's not just, hey, I inject a virus, a spike protein, and you by miracle you develop these antibodies. No, it's a very complex mechanism that our body goes through. These T and B cells develop immune memory of the spike protein. And the question is, how long do these memory cells last for? 6 months, 9 months, a year? And that's our question right now. What's this long-term immunity going to look like? And of course, as you can imagine, people who are immunocompromised, people who have low T cells, people who have who on chemotherapy, people who have dysfunction or dysregulation of these B cell or T cell forming mechanisms by thymoma, bones, transplants, etc. They will have a tougher time developing these antibodies. That's why we're talking more and more about boosters for the elderly. And as we age, aging also declines our CD4 cells. That's why we see shingles break out over time. And as we age, these cells take a longer time to kick up back if you're exposed to a spike protein. So the antibodies remain in the body for some time, ready to bind to the spike protein and block the virus from infecting new cells. And B cells produce more antibodies, but it's important to recognize that we need those memory cells. And those memory cells live for very long periods of time in our body. This is just a more complex look at that story. Looking at the mRNA vaccine, adenovirus, they work in different mechanisms, different pathways, but at the end of the day, they still end up producing T cells, memory cells, and B cells that affect immune response. So that's why I just decided, let's look at how complex it is. It's not as simple as sometimes we think it could be. And then the question is about what is our immune response over time? What does that look like? So here's the 1 dose of J&J in the gray bar, in the gray line. Here's your primary response vaccine after the first dose, and here's over time your response declines. And this is where we look at the Pfizer, Moderna, and AstraZeneca. Here's your first dose, and then your second dose, and then your second dose has a boosted immunity. And then so here we are now, and then we're talking about the booster over time to even boost your immunity more. But as you can imagine, the secondary immune response with people who were over 60, diabetics, people who have delayed immune response will decline faster and will be more susceptible to infections. So that's why we're really postulating, recommending a booster for those patients. So the current vaccination options, I look at the mRNA. Here's a lipid nanoparticle that has to be dissolved to release these proteins, the spike protein, into the system. And it's quite similar with the Moderna vaccine. Again, they both have these and this was the challenge with mRNA vaccine. How can we develop a process that gets into the muscle cells for then that nanoparticle has to be dissolved? For many years, this was really the challenge of developing these vaccines. And I think now that we've developed this story, we're going to hear more and more about mRNA vaccines used for treating or even therapeutic cure for HIV down the road, or even for hepatitis B or other viruses over time. So the Pfizer vaccine is given on day 1 and day 22 in more than 12 years of age, and nowadays the younger group is now available. Vaccines are now available. The initial study looked at 43,000 patients. Again, these are massive studies. This was not done very casually. This was done, in a very scientific way. The data was collected. There's a lot of abstraction data that goes on in these studies at day 4, day 8, day 20, day 30, day 60, day 90. Patients have to be coming back to the clinic to be reevaluated. And when you look at the number of people who are infected, it was 170. There's a 95% primary endpoint of prevention of symptomatic COVID-19. Again, the point here is prevention of symptomatic COVID-19. We never said anything about stopping transmission. We never said anything of reducing transmission. It was all about prevention of symptomatic COVID-19. That was the story is about. There's about a 94% efficacy, and there were 9 of 10 cases occurred of severe infections occurred in the placebo group. And then when you look at the, looking back at that, there was also a large, there were 9% were African American, 28% were Hispanic, 35% were obese, and 42% were greater than 55 years of age. Why did I mention that? It's because it's important to recognize who were studied compared to the current population of people now who are infected in the clinical world. So it's important that whenever you do a clinical study, you have to get the right patients involved. At no point doing a vaccine study and people from 20 to 30 years of age with very low risk of severe infection and proclaim that this is a brilliant vaccine. So what was the side effect profile look like? Common and local systemic reaction, pain, headache, fatigue, because this is your body immune system kicking up, trying to look at the spike protein. And this was reported less frequently for patients over 55 years of age versus younger people, because younger people have a more robust immune system and they were probably responded much faster. The safety and efficacy results were not included in the primary analysis. That was included later. The Moderna vaccine, day 1, day 29, 18 years of age, 196 were positive. 94% efficacy after 14 days for the prevention of symptomatic COVID-19. And there were all the cases that were severe occurred in the placebo group. And then we looked at the safety consideration. Injection pain was common, 88% after the second dose. 79% of vaccine recipients had AEs after the second dose. Fatigue was common. And then the AEs were mild and moderate, and they were injection site pain. We know this. So the CDC said, well, immunocompromised individuals may still receive COVID-19 vaccination if they have no contraindication to vaccine. And this is how we've proceeded over the last almost 9 months now. Patients with HIV might have an increased risk of severe COVID-19, so our patients were very quickly, captured post release of these vaccines. And persons with stable HIV infection were included in the studies, but the data was limited. And then when we look at the real-world data, we didn't see any significant flags to say this, we shouldn't give this. And here's the Janssen and AstraZeneca. These are adenovirus vectors. Is a modified adenovirus 26 for the Janssen, and for the AstraZeneca was modified was a modified AZV, genetically modified virus. So the interesting thing about the Janssen AD26, this was being looked at for quite a few years now even for HIV treatment strategies. So this was not just plucked out of the air. This has also been in the pipeline for quite a while. The efficacy of the adenovirus vaccine, when you look at 43,000 patients, was 85% after 28 days after the dose, and 86% was effective those less than 60 years of age, and 78% efficacy for those greater than 60 years for, again, prevention of symptomatic disease. And the safety consideration quite simple. When you look at all these vaccines, you're going to have some amount of vaccine reaction. You have there's 76% of reaction with systemic, like fever and chills, that was included, but these were all self-limiting and resolved within a few days. 34% of vaccine recipients felt that there's a healthy impact of the benefit of taking this vaccine. However, there was a concern that there was cases of cerebral venous sinus thrombosis, thrombocytopenia, and there's a little concern about these vaccines that have been looked at and been studied. At one time, we said don't use, and are we back to recognizing these numbers are quite small compared to the magnitude of the vaccination program. The AstraZeneca, the Oxford, 79% efficacy after 21 days and 80% effectiveness for those greater than 65 years. So I think the point is this, is that you look at the effectiveness, the efficacy of these vaccines across the board, who would have believed that we would really have these high numbers, 80%, 90% of efficacy developed in such a short period of time, when we still have challenges with other vaccines. But I think it's important, we said the bar was set high, the vaccine data has come out very, very strong. So a lot of people have put their time and work into these vaccine projects and the development of these vaccines. So there's some questions remaining there. There's some questions about COVID-19 vaccines. That couple of things. Most individuals infected with SARS are asymptomatic or develop only mild symptoms, such that the vaccine safety is critically important, because when you want to give a vaccine, it got to be safe. What we have seen over the last year, the safety signals are quite strong. It remains strong from the clinical trials to now. The theoretical risk of concern for vaccine-associated disease enhancement at this time is not supported. I mean, did I have doubts? Yes, I did. I questioned it. Am I going to see cancer? Am I going to see something else? Yes, I did have those questions. And 9 months later, I've not seen any of those flags or signals at this time. As immune function declines with age, this decline is likely a catalyst for greater risk for severe COVID-19. That's why it's so important that the old individuals, the antibodies may wane over time. They need to be boosted, and they need to capture those higher doses of these vaccines that's there. Just a few more slides. Do people with HIV need an extra dose of vaccine? People, yes, they do, especially low CD4 cells. So people who have advanced or untreated HIV, they are going to benefit. I've started doing that in my practice. They're receiving an additional dose, and even other patients are now saying they want to have the booster, because we're concerned that if your CD4 cells are less than 350, you're higher risk of developing complicated COVID. So the third mRNA dose authorized for or advanced or untreated HIV in August, they amended it to include people greater than 60, comorbidities, immune dysfunction. HIV is included in one of those, and this amendment applies to Moderna and the FIDSA. The third dose to be administered at least 28 days following the 2-dose regimen of the same vaccine. So it's important to look at those timelines and get it done. So will COVID-19 vaccine interfere with ART or PrEP medications? Of the 8 vaccines mentioned, none have shown any interaction with HIV medications. And it is not recommended to stop HIV medication when receiving the COVID-19 vaccine. There's no need to do that. And can HIV ART be used to treat COVID-19? At this time, there's no evidence that any of the HIV medication. There were studies that looked at Kaletra, there's studies that looked at tenofovir, there are multiple studies that have looked at some of these medications. And at this time, there's no evidence that HIV medication can be used to prevent or treat COVID-19. And also, it's not recommended to switch a patient's ART regimen to prevent or treat COVID-19. Some HIV medications are currently being studied, but again, we are still far away from getting those answers. So what can people with HIV do to protect themselves from COVID-19? Again, follow general rules, and they are very cognizant of this. Most of my patients are very cognizant of this. They get their vaccine, they keep wearing their mask, they come to my office even though they're vaccinated with their nostrils and mouth covered, and they still create this social distancing as they've seen over time. So they remain cognizant of the risk factors, and they're very pro advocates for their own immune systems. For those with weakened immune system, they may not be protected even after full vaccinations. And we're looking at studies with those group of patients now, looking at Regeneron, looking at monoclonal antibodies to prevent those patients who have less than 200, less than 50 T cells, to keep them, to try to minimize their risk of developing COVID or severe COVID. Again, we mentioned the usual lifestyle for HIV, healthy diet, reduced stress, sleep in, the usual recommendations are there. So when we look at the DHHS guideline for COVID-19 and HIV, we need to, one, assume there's a higher risk for all, especially those with CD4 count less than 200, cardiac disease, diabetes, obesity, age greater than 60, smoking, immunocompromised states. We encourage the hand washing, the social distancing. We do a lot of more telemedicine visits. We try to get people who are diagnosed immediately, naive patients, get them into care quickly. So we try to avoid telemedicine visits for those patients. We try to get them vaccinated as soon as we know that, quite quickly with their T cells and their viral response. We try to get them on treatment with our treatment quite rapidly. In COVID-19 in pregnancy, the clinical management should be same as pregnant individuals without HIV have COVID-19, vaccination, or whatever treatment is necessary. For children, ensure their immunization are current, influenza, pneumococcal vaccine, and now with the COVID vaccines as well. Opioid use, we see a fair amount of that. We start vaccinations again, home care, isolation, quarantine. If they have respiratory symptoms, don't come to the office. We can, get a PCR testing before you get there, so that you won't infect people in the waiting room or in the nearby areas. So viral load, important to get those done. Start those for patient treatment, COVID-19 testing, antigen testing, PCR testing, and recognizing that these higher rates of risk factors contribute to the severity of illness. It's important to do that, and recognize that more than 50% of people in the United States with HIV are more than 50 years of age. It's important to do that. So I know this is going out, this broadcast is going out to Caribbean and different places. So we need to look at your population, less than 50, over 50, but every single HIV patient, in my opinion, should be vaccinated, and they should be vaccinated as quickly as possible. That will be my pretty much closing point or closing statement. Thank you. I know I've gone over time. I know there are probably some questions. Dr. Singh, can I turn that over to you?
Yes, thank you so very much, Dr. Ramgopal, for what is a really, really comprehensive presentation. I am encouraging at this point participants to go ahead, type your questions, submit them. We'll take them at the end of the second presentation during a question and answer segment. But again, thank you, Dr. Ramgopal, for sharing and highlighting some of the similarities between the HIV pandemic, the HIV epidemic, and the COVID-19 pandemic. And I really liked the way you positioned people living with HIV and saying that, there is this bigger goal of protecting their immune system, because they're living with HIV, they understand what this means, and so they're trying to protect their immune system. And I wonder during the question and answer segment whether you may want to respond to that specifically in terms of whether this has kept people living with HIV away from accessing services, and whether this has led to interruption in treatment. But again, thank you. I think you did share specifically in terms of people living with HIV, the evidence that clearly shows the greater risk for severe disease and mortality. So for people living with HIV, male persons living with HIV, people living with HIV with comorbidities, specific age groups, so some of our older age group, people with diabetes, hypertension, and with low CD4 counts. I really appreciate the in-depth presentation in terms of what I'd call the science of vaccine, really taking us through the different types of vaccines that are with us right now, but also looking at the different vaccines that are in the different stages of development. But when I think, when you put all of this together, I think it's just fantastic the way the science has really taken lead in this pandemic, trying to get vaccines for us, trying to get treatment for us, so that we can get out of this pandemic. In terms of the vaccines itself, I think my takeaway message from you at this point for people living with HIV is that, one, people living with HIV should get a vaccine, and two, more recently, and you've shown very clearly in one of your slides how the immune system reacts to the vaccine, the first dose, the second dose, and the need therefore for the third dose or the booster shot. And so I think, so one, people living with HIV should be vaccinated, and two, with the third dose or the booster, that's an additional recommendation that we should seriously take on board. So again, thank you, Dr. Ramgopal. We will take any question and answer after our second presenter. And so at this point, I'll go ahead and introduce Ms. Diana Weeks. She is from Trinidad and Tobago, currently serves as a on the board of director of the Caribbean Regional Network of People Living with HIV, CRN+. She is the interim chairperson of the International Community of Positive Women in the Caribbean, and the chairperson of the Trinidad and Tobago Community of Positive Women. Ms. Weeks is currently pursuing a Bachelor's of Art degree in Psychology at the College of Science, Technology and Applied Arts in Trinidad and Tobago. Ms. Weeks is an advocate in the Caribbean, well known. She's driven in working with people living with HIV. She supports people living with HIV to get their lives back on track, and is really doing her part in helping to reduce the probability of them being marginalized. I know that Ms. Weeks has been in the forefront trying to get people living with HIV to understand what's happening in this current COVID-19 pandemic, and more importantly, to get people living with HIV to take their vaccines. And so I hand you over to Ms. Diana Weeks to make her presentation. Over to you, Diana.
Good morning, everyone. This morning, I would actually talk about my experience being COVID positive, as well as accessing the vaccine, what made me take it, what concerns I had. I would have contracted COVID 4 months prior to taking the vaccine, and it was a difficult experience. Initially, after the recovery process, I was a bit relieved because, of course, in contracting COVID and surviving, my body would have built antibodies, and I was skeptical about the vaccine because, of course, there was a lot of misconception, a lot of myths floating around about the vaccine, and I was ill-informed, and I felt that, okay, I contracted COVID, and so my body would have developed antibodies, and I would not be required to take the vaccine. However, I attended a couple of webinars, and I started having discussions, listening to the Ministry of Health in our country, the broadcast, talking to doctors, and they strongly suggested I get vaccinated. And, I couldn't understand why get vaccinated if I already have antibodies. And, I had a lot of other persons coming to me and saying, this has to be something more to it, because I mean, my body has built antibodies, as a result of contracting. Why then do I need this? And it led me to do research. I did my own research. I asked questions. I asked the doctors what I didn't understand, and had me to recognize that over time, the level of antibodies decreases in your system. And of course, your susceptibility to contracting COVID again is high. I researched, when I researched the vaccine, I would admit that it wasn't, a layperson couldn't understand some of the languages that they used. And I tried to refrain from going to any site, but I sought to get information from, the credible sites. I tend to tell persons that I try to stay away from the conspiracy theory, simply because as a person living with HIV, and it's difficult enough having to face discrimination and all the other factors. And there is enough fear and paranoia that I am not going to add to it. And so, what I didn't understand, I went to the doctors and I asked the questions, I researched, what was efficacy, because I couldn't understand those terms. Some of the concerns I have with regards to the vaccine, of course, you always hear from your practitioner, you have to be careful about falling sick because of your compromised immune system, and I wondered if I do get COVID another time, because I don't know the impact. Having contracted COVID once already, I don't know what the impact was on my body. And if I contract it a second time, how would that impact my quality of life? What would it look like? Um, with regards to my status, I was concerned about privacy in terms of having to go to the doctors, to access the vaccine, in a space where other people are, and having to tell them, about my status. Um, those were some of the concerns. I could safely say that I decided to access the vaccine with a group for support. And the experience was really a pleasant one. Initially, I had decided, I'm not going to deal with the, I'm not going to disclose my status. I'll just take the vaccine, and that's it, you know. I ended up disclosing to the doctor. She really didn't rush. She took about, and I disclosed my status to her. We had a conversation, and she asked, "Do you have any concerns?" And I told her, I said, "Could you tell me what I should or shouldn't do after getting this vaccine?" And I think one of the key things was, she said, you have to get rest. So if you're going to work, make sure it's light duties only. Take Panadol and take your vitamin C, and you should be well. When I took the vaccine, general soreness in the arm, that was it. And I really attribute that to the advice that the doctor gave. Um, Now that I have taken the vaccine, I really feel some measure of protection, especially with the wave that we're experiencing with the Delta, because I also did research in terms of how the Delta um, attacks the body, and these different things. I feel, you know, a certain measure of protection. Of course, I practice the wearing of the mask, washing my hands, sanitizing, um, practicing the social distancing. And I feel as though I have a fighting chance that I may not necessarily have had I not taken the vaccine. If I had to give any key messages to healthcare workers that would encourage people living with HIV to take the vaccine is, you know, practice patience, you know, don't rush the process, you know, um, and generally try to answer the questions in a way that persons would understand. Too many times I've seen persons have fears and they have questions, but because they are afraid they might be perceived a particular way, or they think that the question is a stupid question. And, I like to say there is no stupid question. You know, they stay silent rather than speak out. And I want to say that one of the things that we sometimes do not take into account is the fact that in some ways, living with HIV has prepared us. If we take away the panic and the fear, living with HIV has prepared us to kind of deal or live with this virus, simply because as people living with HIV, we face discrimination. So we know what it is to face discrimination that COVID positive persons would face. We know about the uncertainty, and these different things. So if I had to give people living with HIV key messages, is to not to buy into the conspiracy theory. Do your research from credible sources, talk to your doctors, ask questions, get a doctor visit first, and let them advise you as to whether you're eligible for the vaccine or not. Practice the 3 Ws: wash your hands, wear your mask, watch your distance, and overall, rather than sit and your mind and have all these thoughts and these questions and just sit there, talk to somebody and talk to a credible source. For those who have not taken the vaccine, speak to your doctor. Speak to your doctor. That is, visit your doctor, consult, and the process is not as frightening as one would believe. And even after you've taken the vaccine, you still have to be careful not to contract COVID. And so Be aware of your body. Be aware of any changes in your body. Do not wait until you feel severely ill to seek help. And you know, that I think is my key takeaway. You know, speak to your doctor and get vaccinated. And that is basically my presentation, Shanti.
Yeah, thank you so much. Thank you. Thank you very much, Diana. Thank you for sharing your story, your experience with COVID-19, and also the approach that you use to get information that really allowed you to make a decision around taking your vaccine. So the questions that you've had to ask and the way you've gotten answers to those. So, and just to recap, looking at credible sites where you can get that information. Really relying on your healthcare practitioner to take you through the basics for you to understand some terminologies that are being thrown around there right now, things like efficacy and so forth, and be able to ask questions and get answers. I really like the way both yourself and Dr. Moti has positioned the community of people living with HIV, saying that you've been prepared, you are prepared to deal with this. If you put aside the fear, the stigma and discrimination and the uncertainty, you are prepared to deal with this pandemic. So get your information from credible sources, talk to your physician, be able to put aside and distill and put aside all of those information that's not credible, and to really go with the basics. Wash your hands, wear your mask, do your social distancing, get your vaccines, and now we're talking about getting the booster shot. So thank you again, Diana. Thank you very much for sharing your personal experience. I'm going to encourage attendees to go ahead, submit your questions. We have a few questions already, and I'm going to pose them to Dr. Moti and to Diana. So the first question is for you, Dr. Ramgopal. So you spoke a lot about the mRNA vaccine, Pfizer and Moderna, and the Johnson & Johnson, but you know, in the Caribbean, we've been using AstraZeneca and some other vaccines. And so many of our countries are already talking about the booster shot, but having used AstraZeneca and Sinopharm and Sputnik vaccine, what's your recommendation in terms of that booster?
So that's a great question, and it brings down, really circulates around the question of mix and matching. And there's a lot of data out there now that's showing that if you can mix and match vaccines, and you'll still have a boosted immune system. You're really boosting your memory cells, you're really boosting those CD4, you know, the macrophage, the T cells, the B cells. And the question is, when you look along the adenovirus platform versus the mRNA platform, you see that the efficacy is over 80%. So it doesn't really matter which one you take. I mean, once you get a booster, it will help, because it will help boost, especially if you're in those higher risk categories that we mentioned earlier: obesity, the diabetics, the over 60, the immunocompromised patients. So I think whatever is available, I think the data supports all of these vaccines as a certain really high level of efficacy across the board. Maybe Sinopharm, maybe Sputnik, maybe they're all pretty much similar. And they're very similar in their response, except there's a little difference in mRNA. You see the mRNA is around 90%, and everything else is around 80%. But I think those narrow margins are small, and I think if you have the choice, whichever one's available to you, you should take it.
All right. Thank you very much. This question goes to you again. Many countries do not do baseline CD4 at this point in time. So do you think it is time to revisit this decision now that we're seeing that there is a link between low CD4 and COVID-19 disease and mortality?
So I think that's an easy question to answer, and I think the question answers itself, of course. I mean, the CD4 test now is very cost effective and not like it was 10, 15 years ago. And I find it difficult to understand how we will treat an HIV patient without doing CD4 testing. I think it's a guide. It helps patients to adhere to treatment. Not only that, it gives us an immunological profile of that patient. What's their CD4 percentage? Is it 14? Is it 20? Is it 8? Are they at higher risk for PCP? Are they higher risk for complications? And why isn't that CD4 not going up? Is it related to viremia, you know, chronic? There's so many different reasons why that may not go up. So I do believe that we need to invest in our CD4 testing more throughout Guyana and the Caribbean. I think the strategy of, you know, viral load testing needs to become commonplace. The cost of these and the machinery and equipment for these are very low now, and I really think governments and communities and private-public partnerships should have these tests in. We really need to amp up our testing in Guyana and the Caribbean significantly in the next 5 to 10 years. I mean, it's not like we're in the stone age of virology anymore, or the stone age of infectious disease anymore. The PCR machines are there. They're not that expensive anymore. They're running these machines are quite cost effective. The benefit and the value it will bring to the communities and the societies in Guyana and the Caribbean is immense. So I think we need to re-look at how we're doing our HIV. I do CD4 testing at least 2 to 3 times a year, and I think I do my viral load test at least 2 to 3 times a year. The cost of that to my patients is probably less than $100 relatively. The more you do, the cheaper the cost is. The less you do, the more expensive these tests are.
All right, thank you, Dr. Ramgopal. The next question is, what is your take on Covaxin and Sputnik vaccine?
So I've mentioned that briefly. So my take on the Sputnik is that they're adenovirus based, and they're very similar to the AstraZeneca and the J&J in their clinical response. I think they're very efficient and very effective vaccines. I think they're well developed. I know they've been fairly well studied. I think as vaccines go, as vaccine candidates go, they're very important. The challenge for those vaccines is that the acceptance in the international community. I think now that the Sputnik data is in front of WHO, somebody needs to make a decision on these vaccines soon and say, are they good enough for the rest of the world? Scientifically and clinically, we've seen the data out there to some extent. The FDA, the European community, they need to say, what data do we have on these vaccines now? They've been used extensively around the world. Let's get the data, let's look at the AEs, look at the side effect profile, let's look at the clinical, the progression to severe COVID. Is it 80%, 90%? I think we needed stronger data, but clearly the vaccines are quite effective.
Thank you, Dr. Ramgopal. I've just put the result of the poll up. Diana, any comments, any reaction to what we're seeing from the poll here? So 92% of our audience this morning would recommend the COVID-19 vaccine for people living with HIV, but there are 8% that's saying maybe. Any reactions from you, Diana?
Definitely. We have not had, or I'm not aware of any adverse, reactions or events associated, and it could only benefit us, especially from having a compromised immune system. So I definitely would recommend, of course, again, speak to your doctor, consult your doctor before you make any decision, and base your decision made on the recommendations made.
Okay, awesome. Thank you, Diana. Dr. Moti, any comments on the poll?
Yes. Okay. Am I unmuted? Yeah. So the 8%, I think they need to rethink why there may be, and there may be other reasons why they're thinking for specific patients with resistance, I guess, vaccine resistance, but I don't see why we can't get more. I think I'm very impressed with 92%. I can take that. the 8%, well, I hope we can convince that 8% to think that everyone probably should get vaccinated with HIV. Maybe a little bit more, convincing, more data, more understanding the mechanisms.
Okay, all right. Thank you so much, Dr. Ramgopal. We have a few questions.
Sorry to interrupt, but it was good to see that nobody said no. So that's good.
I think that was really good, and I agree with you. I think 92% is really, really good. So we have a few more questions. Is it recommended that we monitor the antibody titer of patients as it relates to the booster shot?
So antibody titers, there are very few labs doing it. I started doing it recently in the US with some patients, especially patients who are immunocompromised and they're questioning getting a booster. So I would get a lab to show them, look, your numbers are low, or you need a booster. So I think for small select group, there may be an indication, but as a majority at this time, no, because we don't have a good specific test, and as we've seen the variant. So coming back to the questions of vaccines, and I think personal story is always good, because about a year ago, in midst of working, I became infected with COVID, and of course I always think that, well, I have COVID antibodies now, I have not immunity from actually acquiring the infection, but yet I still decided to go and do the vaccines. Why did I do that? Is because I'm concerned about the variants, I'm concerned about my immunity waning over time. So for those same reasons, I will advocate, we need to consider, taking that booster without really worrying about your antibodies, because is it going to cover more the variants, more strains? I think so. There's data that suggests that. So that's the reason why I strongly encourage doing the boosters and not necessarily doing the antibody testing. But I think the antibody testing is just also useful for certain people.
So. Thank you, Dr. Ramgopal. I'll take one final question, and I think it's linked to the response that you just gave. But if there's anything that you want to add, and I know we're way above time, so I'll take this final question and then we'll wrap up. Is there any information on the levels of immunity conferred by COVID-19 vaccination vis-a-vis infection? So anything that you'd like to add to your last response?
That's a brilliant question. And I have this debate several times with lots of healthcare workers who said, I'm not going to take a vaccine because I'm already I had an infection and I'm protected. So it's a really, really good question. We don't have the clear knowledge of this, the scientific knowledge. We have seen that people with previous infection are now getting more infections. The last several months, we didn't see that. So here's a clinical observation, is that one, that people who were previously infected were not a significant piece of the last wave. But moving forward now, as we're seeing there's breakthrough vaccine infection, now we're seeing patients getting recurrent infection. One of the worst cases I've seen with COVID, and I have to mention this, was a nurse in the hospital about a year ago. She was infected and then she got reinfected a few months later. And up to a year later, she still remains intubated on ECMO machine. This is going to be the longest case of ECMO machine ever used. And that shows you, even though there are small numbers of people being reinfected. So to truly answer the question, there's no information that shows that difference of natural immunity, of infection indicated immunity versus vaccine immunity. No, there's no good data, but I strongly believe having an infection is like a vaccine, but not the full course of a vaccine. I still think you need at least 2 more doses after that.
Okay, great. Thank you so much, Dr. Ramgopal. I think we've gone over time, but we've had a really comprehensive presentation from yourself and from Ms. Diana Weeks on COVID-19 vaccines and people living with HIV. Good take-home messages for all of us and for the community, specifically for the community living with HIV. One, that the community is at high risk for severe disease and for increased mortality or decreased survival. And more importantly, the take-home message is that people living with HIV should get their vaccines, and get their booster shots. At this point, I would like to ask if there are any final comments from you, Dr. Ramgopal, briefly, very quickly in a minute, and Diane, 1 minute for any final wrap-up messages.
Final wrap-up is here. We still have another wave or two to go. We need to vaccinate everyone. I think we need to, we need to be optimistic that COVID is going to be with us for a while, but we have better treatment strategies. With pills will be coming out soon. But for now, we have vaccines, and I really think everybody need to keep social distancing, wear your mask, and do necessary preventative strategies that we've been advocating for quite a while now. Thank you so much for listening to us.
Thank you, Dr. Ramgopal. Diana? I think we have lost Diana, but at this point, let me go ahead and say thank you to Dr. Ramgopal and to Ms. Diana Weeks for presenting this morning at this webinar. Thanks to all of our partners for their collaboration. This is a gentle reminder to all of you that a post-webinar evaluation will be in your email boxes as soon as we conclude this webinar. Please complete the evaluation. Let us know what the experience has been like and how we can improve that experience for future webinars. This, I have to say, is our final webinar for the year for PANCAP, and so I want to take the opportunity on behalf of my director, Dr. Rosamond Adams, and the staff of the PCU to thank everyone for their support to the work that we do in the region. Thank you for staying engaged with the work of the partnership. We wish all of you and your families the best over the holidays. We look forward to continue working with you in the new year. Please continue to stay safe. As Diane says, wash your hand, wear your mask, and make sure you keep your distance. For all of us, the booster for countries that are implementing the booster shot, that we consider seriously to make sure that we're vaccinated and we get our booster. So thanks again, everyone. It has been great working with you this year, and we do look forward to working with you in the next year. Continue to follow us on PANCAP social media platforms. Visit us on the PANCAP website, where you can get more resources on HIV and COVID-19. And again, thanks. Stay safe, everyone. Have a good day.